Hi everyone, my name is Moshe Cohn, and I'm here to talk to you today about moral injury and why our words and our language matter. I'd like to bring you on a journey to understand what has become a public health crisis, to explore the language of moral injury and how it's affected us in the pandemic, and to see where and how it can be fixed. Before we jump in to some heavy stuff, I want to take a moment to acknowledge that you're all here because you love medicine, the art and the joy of helping others who are suffering. And it's that love of humanity that I want us to stay in touch with. It's so important for us not to lose sight of that. And it's really why you're here today and why I'm inspired by all of you and how we can remain hopeful. I would say that it's pretty rare these days that anyone in the healthcare profession, doctors, nurses, respiratory therapists, transport teams, even hospital administrators, it's rare that anyone does this job, takes this job with any objective other than to provide the best possible care for their patients. We show up because we care. And it is an awesome privilege to walk the corridors of the hospital, to feel the responsibility and the privilege that comes with our position. And we've earned it. We earned it because we care. But there is a problem. In 2019, 40% of healthcare staff in the UK reported being unwell due to work-related stress. Less than a third of them felt supported by their organizations. And in the United States, over 20% of physicians are leaving medicine due to moral distress in the workplace. These numbers represent a very real and painful human cost. We know that patient satisfaction is much lower when there are high staff burnout rates, and the tragedy that health professionals, doctors in the United States have a suicide rate that's twice the general population is something that is just not acceptable. So we shouldn't be surprised that the rates of this distress, this thing we're calling burnout for the past 10 years or so, that the rates are so high. It's over 50% of physicians, 40% of nurses have these feelings of exhaustion, ineffectiveness, cynicism, depersonalization, a sense of a lack of accomplishment. The numbers keep creeping up and the turnover rates rise. So over 900,000 patients switching doctors because their doctors either are leaving or they're not available. Replacing a doctor costs upwards of $1 million, and it seems to be getting worse. And patients are struggling. So I'm here, and we've arrived here because in the years leading up to the pandemic, and now even more so, we've watched our friends and colleagues, really good doctors, deciding that how we're asked to practice medicine is just too much. And we're tired of seeing them leave medicine, or worse, staying in medicine, unhappy, unavailable to their patients, to their family, friends, to themselves. And even more tragic, dying by suicide. Medicine should be a place where people with the best of intentions can really see their work fulfilled and do the right things, the good things together for their fellow human beings. And we're being prevented from doing that. The language of how we've gotten here is crucial. Why does it matter? because the most basic of human needs is that we want to understand each other. I want to understand you, and I want to be understood. Ralph Nichols describes the best way to understand people then is to listen. We should listen to each other and observe our body language, our facial expressions, and we then mirror each other. And we're not being heard. And in healthcare, it's about time that we're heard. So what is the issue with the current language around burnout? Burnout has become colloquialized. It's not specific enough, and it's insulting. It implies that the clinician is responsible. The doctor is frail, and we know that healthcare workers are some of the most resilient people out there. But most importantly is that clinicians themselves are saying, no, that's not the right term. That's not the right description for what we're going through. Another way of thinking about this is through a parable where a doctor is standing on the side of a river with lots of rapids and sees somebody floating down unconscious, pulls the person out, performs CPR, but unfortunately they've died, and then goes back, sees another body floating down, pulls them out, performs CPR to no avail, and keeps repeating that and wondering why the CPR isn't working. Instead, he should have been thinking about why people are jumping into such a dangerous river to begin with. And this is the issue here. We need to think about what's happening upstream. So Wendy Dean and Simon Talbot started thinking about how to clarify this language. Burnout is the effect, but the cause, the upstream cause, is moral injury. And if we don't address the cause, then the effect will go on forever and it won't end. But where did moral injury come from? So Wendy and Simon arrived at this term because when they looked at what it is doctors were struggling with, it's very similar to a term used to describe an invisible wound that soldiers experienced and suffered when they were either witnessing or perpetrating unspeakable acts in the context of war. And it is not like PTSD, where it's based on fear, but rather it's a feeling of the erosion of a person's sense of goodness and humanity. And in medicine, our deeply held moral beliefs are brought to the surface. They're brought out in our training and our education by the oaths that we take to always put the patient first. Always. And then moral injury describes the challenge of simultaneously knowing what care patients need, but being unable to provide it due to constraints that are beyond our control. We know what they need, but something's in our way. Something's keeping us from providing it. These constraints in healthcare are the things that are keeping us from our patients, focusing on practice metrics or productivity, looking at the computer screen, patient satisfaction scores rather than patient outcomes, reduced staff and lack of autonomy where we have less control over how we provide care. We have less latitude to be creative in meeting each individual patient's needs. So in 2018, Wendy Dean and Simon Talbot took these obstacles and put them to a test, a thought experiment, and asked their colleagues and fellow physicians, how they related to these obstacles, these constraints. And this burnout that they were being told they felt was really moral injury. That is what resonated with them. And it went viral. It was the most read article in 2019, even though it was published the year before, and it's the 5th most read article ever for Stat News. And then Zubin Damania, or ZDogg MD, did a video based on the article, and it got 7 million views. This clearly resonated with doctors all over the country. And about a month later, different authors described the same concept, moral injury, and how difficult it will be to fix, completely independent of Wendy and Simon's original piece. And what's really interesting is that surveys on moral injury tracked burnout scores in a parallel fashion, but also in a leading fashion, meaning that you can see the early stages of burnout in moral injury, and perhaps that provides opportunity to preempt it. So moral injury and burnout are clearly related, but burnout, as we see it, is the end stage. And there are many pathways to burnout outside of moral injury. Other stressors like personal, family issues, health issues, substance use disorders. But in healthcare, it's the double binds. It's the things that are preventing us from quality patient care that ultimately cause episodes of moral injury that then, in a repetitive fashion, lead to burnout. I remember a conversation with Wendy last year in the height of the pandemic, worrying about what our colleagues around the country were going to experience in the wake of the surge, having come into the pandemic morally injured, and now they're pushed to the brink. The frontline experience is like nothing any of us had experienced in our lifetimes. We all experience the problems of staff, stuff, and space every day. And then a pandemic hits, and we simply weren't prepared. The system wasn't prepared, and could be catastrophic. So we all watched, either in front of us, next to us, on TV, how the pandemic hit a healthcare system already caught in an epidemic of clinician distress. We've talked about the suicide issue, and during the pandemic, the feelings of distress have skyrocketed, and our colleagues may leave patient care far earlier than they ever expected to in their careers. This is, again, why language is so important. We need to be able to define what we're feeling, what we're experiencing. We need to know the truth of it. That will enable us to support each other and support our patients. So this isn't new. And healthcare systems have known this for quite some time. But they've looked at it as addressing burnout for individual clinicians. They've gotten turnkey programs from industrial or organizational psychology, the military, to just treat the symptoms and just at the individual level. And these programs try to address the stressors, double binds early on in the process by focusing on boosting resilience in individuals or by identifying those who are burnt out and offering mental health resources. And many of us are familiar with these resilience programs offering yoga, exercise, gym memberships, nutrition, recipes, maybe some increased downtime. But most physicians already know this. They know the importance of these things, and we're tired of being told that we're not doing enough. We're not doing enough to maintain the machines that we're expected to be. And what we need to be doing is looking at the problems within the system that are wearing down our resilience. And recent research backs this up. Physicians score higher in resilience than the general population. And even physicians who are the most resilient also have significant rates of burnout, which we wouldn't expect to happen. If the most resilient physicians are also burning out, then solutions coming from outside healthcare focused on resilience seem less likely to be the right ones. And if they're focused on burnout, then they're likely too late. In 2019, the loudest official signal of this problem came from the National Academy of Medicine in their report on burnout. And they said that the evidence for system interventions is limited, and the committee was not able to provide specific recommendations for systems interventions. And that was alarming because it means that for a decade, we've been trying to treat burnout and it's failed. And what are we missing? And so we then have to think maybe the diagnosis is wrong. Maybe this is not burnout. So we think there is a better way. There is a better approach by looking at it from the perspective of moral injury. Resilience, we know, is the wrong focus. We have resilience in spades. And applying mental health resources to burnout, as we've said, is too late. We think the better approach is systemic solutions that focus on the barriers to care, the barriers to clinicians doing the jobs that they feel morally committed to doing. And so the change has to be bigger than we've imagined in the past. We can't fix systemic problems by addressing individual issues. I think a year ago, this question would have raised some more eyebrows, but we've learned so much. There are real opportunities from the past year that can help us here. Death was at our door every single day. It uncovered gaps in the system, and we have the opportunity to reflect. And I've spoken to so many colleagues who've said to me, we set aside some of the regulatory requirements because we needed to just take care of patients. And for the first time in a very long time, I felt I could just be a doctor. We've adapted so well, more than I think we might have expected, to change in crisis. We've pivoted to telehealth, And we actually can do things, big things, fast. We just need to be motivated. And this system needs to be motivated. For us to take the next steps, the right steps, we have to share certain assumptions from the start. Number one, and most important, is that the system is broken. It is not about the individual and their flaws and their strengths, but it's about the system, and the system needs fixing. But we can fix it when we work together. That's always better. We know that. But we need to recognize that changing this system, this restructuring, it takes time and a lot of effort, and accepting that small wins matter. That is what will lead to the big wins, but we need to start small. So, what do we do, our group? Moral Injury of Healthcare is a nonprofit that was started to raise awareness um, of the problem, of this issue of moral injury, to advocate at the government level and in professional societies, and then educate through workshops and programs like this, and to solicit and facilitate research to quantify moral injury and really identify interventions, um, and ultimately to help and consult with healthcare systems, hospitals, private practices to find real workable solutions to take care of their most important resource, their frontline healthcare workers. One of the most important ways we do that is by listening. We have heard from so many clinicians suffering from moral injury, and we want to continue to hear from them. We want to continue to hear from you. Listening to each other is, as we've said, how we are going to be able to step forward. The more we hear from you, the more we hear the stories of moral injury, the better we're able to define the problem itself in a way that will benefit the most people. When we define it, we can find solutions. With a definition in hand, we then refine the language, refine the communication, and translate for hospital leadership, for non-clinician executives who run most of our hospitals, so that they can address the problem. They want to address it. They want to make the lives of their workforce better. And so we facilitate that. We show them how. So we're often asked by clinicians, what can I do? What can I do to help further this process? What can you do? What can you do? What we would ask is that you use your voice. You start by identifying the daily challenges, the obstacles that you face in providing patient care, and use that as an opportunity to build bridges with your executive team, trying to align your values by seeking to understand how they think, ask questions, be curious. At the same time, stand up for clinicians, demand respect for clinicians. Um, and one way to do that is to offer solutions. If you're asked to develop strategies or programs to participate in fixing the problem, raise your hand. Don't be shy. You want to support the leadership that is supportive of you. You want to support the good leaders. Um, we can all think of examples of leaders that we'd rather not work with. But rather than focus on those, focus on the ones that are really interested in making the changes that we've been talking about. The ones who are willing to ask questions, who are willing to seek to be united with you and are not afraid of conflict. The ones who have the servant mindset and who are looking out for you as an individual, for your team, as a pathway to the best patient care. One way to identify who these leaders are the people who are willing to kind of get down and dirty, the people who are willing to step up next to you and really see what you're experiencing, to see the difficulties you face in person. Those are the people who are showing that they can be trusted and relied upon to make things better. There are also clinician leaders who are the ones who are always alongside you, but then go one step further. They have the ability to break down barriers, and it's that mindset that allows them to guide the team, to guide you and develop your talent and develop the talent of others without worrying about their own egos. And that is how a team grows and shows strength in the face of major obstacles. Those are the people you want to align with as well. In addition to finding the right leadership, it's identifying the things you can change. The little pebbles in your shoe, the personal things, part of your own workflow, in your workspace, in your unit, the local issues, and the things that are possible. If we look at the broader issues, they get overwhelming. And so we have to really shrink that change down, again, to what's personal, local, and possible, and then stack them up, gather them up. And then we can step back and see the big pile of change that we've created. Make sure you celebrate the small changes. You put them in place and celebrate the win and make sure they stick. And then quantify it. Make sure that you have something to show for it and then share it, not just with leadership, but with colleagues laterally across the system, across an organization. That's how the wins pile up. And we deserve to celebrate each of those wins. So what does this look like in a practical sense? Carlina Rivera was a guest on our podcast. She's a member of the New York City Council and described how her mother would say that you rebuild a community by starting first in your house, then your building, then your neighborhood, and then your city. You can't start with the city. That's too big. In healthcare, that means you start in your office, in your workroom, then maybe your floor, your unit, your division, your department, and perhaps your hospital, your whole organization. It has to go that route. You can't skip steps. But when you do that, you have a solid foundation for change. I want to remind you that individual resilience is not the issue, but community resilience is absolutely necessary. If we're not resilient together, then we're not going to be able to withstand a crisis. It can't be just in time and all of a sudden we're resilient. There's a an amount of social capital. We need to be able to trust each other, and that trust has to be really solid and prepared for bad times. We have to be able to trust each other, respect each other, not only our colleagues, but our leadership. And that has to go both ways. We have to give them the benefit of the doubt, and they have to give that to us as well. There are going to be bad days, and we need to be able to trust each other in order to get through the harder times. We can also take a page from the corporate playbook. In 2019, the Business Roundtable redefined corporate purpose and refuted the idea that the sole focus, the primary obligation of any corporation is to increase value to shareholders. It's something that had eroded social fabric by focusing all of US business on nothing but profit. And that included healthcare. Even nonprofits had that same idea. And so they said, no, we can't do that anymore. We need to return value to shareholders, but also prioritize customers and employees and communities as key stakeholders. And in healthcare, those stakeholders, that's us. And then our role is to help redefine the purpose of US healthcare and US healthcare institutions to include and prioritize healthcare workers as key stakeholders. And of course, finally, you can join us. Visit our website, join our mailing list, send us your stories. I think one of the most helpful things you can do is contribute to the big story of moral injury, of what's going on that is causing so much distress for us and for our colleagues. Your stories are what allowed us to be here today. Listen to our podcast, Moral Matters, and subscribe it and share it, and follow us on social media. We want to see you, we want to hear from you. The pandemic has shone a white hot spotlight on the challenges of our healthcare system and those around the world. It's shown us the gaps and has given us the time to reflect on our purpose, on why we show up every day. The problem is that we don't have a map. We don't have anyone guiding us, but we do have goals. We do know that we aim to just make our patients' lives better by improving their health, by caring for them. But we also need to make it sustainable for clinicians. It has to work for us. If it doesn't work for us, it's not going to work for our patients. That's very obvious. So we need to orienteer. We need to use our navigational skills and create a map as best we can, our own maps, and knowing that we're all going to meet somewhere at the goal. The guide is our moral compass, and the patients are our true north.